Good evening, everyone. I'm a faculty at NRI. My name is Saroja Voruganti, and it's a pleasure to introduce Dr. Emma Allott. Emma joined the NRI in January as a visiting professor, assistant professor, and she's been enjoying her time in Kannapolis. She's originally from Dublin, Ireland, and completed her Ph.D. in tumor biology at Trinity College, Dublin, before she came to North Carolina in 2011. She did a postdoc at Duke University. 7 years later, she's still here, enjoying, although she's a little confused about who to support in college basketball. She enjoys the local live music scene in North Carolina, barbecue and beer, and most of all, she loves friendly and welcoming people. Sadly, for us, she's moving back to Ireland this summer to be closer to her family and to start a new faculty position in Queen's University, Belfast. She'll be continuing her research in prostate cancer. This evening, she's going to share with us some of the research, providing an overview of the challenges and unique possibilities for improving our understanding of the disease. Welcome, Dr. Emma Allott.
Lovely introduction, Saroja, and I hope I have this all set up okay now. I'll try not to touch it again. So as Saroja said, I'm excited to be here. I've been to a couple of the Appetite for Life presentations this semester and have enjoyed them a lot, and so I hope I can measure up to some of the great other speakers that we've had. My real, and we have all generations here. That's really nice to see. And different species. So my real love for research is around prostate cancer, and many people in cancer research get asked, what is your personal reason, or what drives you to explore this particular cancer type. And often people have a story about friends or relatives, and I have to say, for prostate cancer, I really don't. I feel like what motivates me to study prostate cancer is just how little is known about the disease compared to how much of a burden it is for the population. And I see the progress that has been made in other types of cancer, and I believe that we can use some of those lessons to do better for this disease. And so that's really my motivating or driving reason for studying the disease. And I hope to share some of that interest and enthusiasm for learning more about this cancer type with you tonight. Please feel free to stop me whenever you'd like to ask a question. It would be nice if we could have an informal discussion. So feel free to do that. Saroja very kindly introduced me, and I don't really have more to add from that, except that I've had sort of a transition through the last decade of my training from working at the bench side to working more with human populations. So beginning with sort of experiments on cells, cancer cells, and what they do in a petri dish, to doing data analyses in large populations of usually men at risk of or with prostate cancer. And so my real interest in the area of research is to incorporate kind of lessons from both of those different disciplines of research to try to move things forward in this area. All right. Of course, I forget the instructions now, but there we are. So I've promised you this will be the only graphic depiction of the male sex organs, but I've just encountered a number of questions over the last years, that not everybody is really very familiar with the prostate. And so I just wanted to quickly point out to you that it's this organ, it's a walnut-sized gland that sits at the base of the bladder in men. It kind of surrounds the urethra, or the tube that through which urine is expelled from the body. And so this is it here. And the prostate, its function is to secrete a fluid that bathes the sperm to form the semen. And so that's what it's doing there. And one of the proteins that it secretes is called the prostate-specific antigen, or the PSA, we'll call it. And I just mentioned it here because that's one of the key proteins produced by the prostate that we're interested in because of screening. So to start by sharing some statistics with you, and I feel like this is a common graph that everybody in the prostate cancer research field looks at a lot, but that possibly you guys haven't seen before. And so this just shows you the number of new cases of prostate cancer that are diagnosed each year in the US. And these are calculated using a large national cancer database called SEER. And so these are SEER data capturing the population, the US population. And so here we're showing the number of prostate cancer cases per 100,000 men in the US. And this green line is the new cases diagnosed. You can see the shape is a little curious. Of course, I haven't shown you the shape of the rates of new cancer diagnoses for other cancers, but prostate cancer always looks quite unique. And whenever I show this graph to students, I always ask, can anybody in the audience, so here's a test of audience participation if you choose to accept it, can anybody hazard a guess as to why there's this big spike in the mid-90s in rates for prostate cancer?
Better detection.
Screening. Better detection and screening. So, thank you. So this reflects the introduction of the PSA screening test, the blood test for prostate cancer. And so prostate cancer is the most commonly diagnosed cancer in men in the US after skin cancer. And approximately 1 in 8 men will be diagnosed with prostate cancer during his lifetime in the US today. And so the other big question that I feel like I often get from people when I tell them I'm studying prostate cancer is, why study prostate cancer? It's kind of a boring disease. It doesn't contribute. Men survive for a long time with prostate cancer. It's not a really lethal cancer like we think of for lung or some other cancer types. But actually, it's the second most common cause of male cancer deaths in the US. So many men live for long periods and don't experience really severe symptoms from prostate cancer, but others have a very aggressive form of the disease, and there is a burden of mortality associated with this cancer. So while the lifetime risk of being diagnosed with prostate cancer is 1 in 8, the lifetime risk of dying from prostate cancer is a lot lower, more like 1 in 40. Still a sizable number of the US population, though. So because I feel like the screening test is so relevant to the prostate cancers that we're studying today, I thought that I should include a slide just to give you a little background on prostate cancer screening. And so this is particularly relevant today because actually just last week, the US Preventive Services Task Force, which are a body in the US that review evidence and summarize evidence supporting prevention of different diseases in the United States. And so they've just released their updated guidelines for prostate cancer screening. They had them actually, they released them last year, had them open for a year of comment, and then published the final guidelines last week. And so again, we're talking about PSA, which is a prostate-specific antigen produced only by the prostate. And it's mainly secreted, as I mentioned, into semen, although a smaller amount of it does get into the blood. And so this is the whole basis of the PSA, or the blood test for prostate cancer. And so I wanted to mention here that the PSA, the amount of PSA synthesized and secreted by the prostate depends on how big the prostate is, and depends on a number of other factors, like whether there's cancer in the prostate, which is growing more quickly than normal cells and producing more PSA. But there are also other reasons that you might have an elevated blood PSA. And of course, this is one of the big contributors to the controversy around prostate cancer screening, because it might not just be the prostate cancer. Inflammation from injury or infection can increase PSA, as well as a very common condition, which is just hyperplasia or benign growth, non-cancerous growth of the prostate, which very commonly occurs in older age. Oh, yes?
Sorry to interrupt, but
No, absolutely.
can that prostate inflammation be caused by an inflammatory diet?
So it's interesting. Prostate inflammation has been in sort of an intriguing area of research to me, because it's actually been shown that about maybe 60 to 80% of men without prostate cancer have some evidence of prostate inflammation. And the reason we know that is because many men are getting biopsies to check for prostate cancer, and so we do see inflammation in quite a few men. And so some studies are starting to try to explore reasons or causes of that inflammation. And there's still only very few studies in that area, but one of them did look at diet and saw that levels of, so what they looked at was omega-3 and omega-6 sort of pro and anti-inflammatory fatty acids, and how they were related to the level of inflammation in the prostate. So it's sort of just the beginning of an intriguing idea that our exposures, our diet, and potentially environment and lifestyle could in fact influence the prostate biology, providing sort of a mechanism or a reason why those factors might be linked to cancer. Does that answer your question all right? Yeah. So that's something that I'm working on at the moment. I think that's a really interesting area of research. And then I thought I'd show you a little timeline on the PSA screening test. So it was back in the late 80s that the PSA test was first approved. And you'll notice here it wasn't approved for screening. The PSA test, the blood test, was developed for tracking treatment and response to treatment in prostate cancer. That's how it came to be. It was only once it was sort of in the clinic that people began to wonder if it could be used for screening, so for picking up new prostate cancer cases rather than for monitoring response to treatment in existing prostate cancer cases. And so it was introduced, and you notice the spike in incidence when it was introduced in the mid-90s. Following that, there were two large randomized control screening trials conducted, one in the US and one in Europe. And the results from those big trials, which tested whether introducing prostate cancer screening with a PSA test could reduce mortality from prostate cancer. That was the purpose of those two trials. And they found, in 2012, they published their results showing that there was no benefit for screening. And so the US Preventive Services Task Force changed their recommendations in 2012, and PSA screening fell way off. And then the most recent, I told you this was an updated slide just last week. They have modified, so part of the challenge is because prostate cancer is generally such a long, slow progressing disease, you need just a huge amount of time to continue following those men who participated in the trial to see if screening really did reduce mortality, to just have enough numbers to properly assess this. And so with the additional follow-up, we now see more promise that PSA screening could, in fact, reduce mortality or deaths from prostate cancer. And so the screening task force, or the Preventive Services Task Force, have sort of modestly updated their recommendations to say that screening can be implemented, but it should be discussed on an individual basis with your physician. So there's a lot of controversy in prostate cancer in this area, which has been interesting to track over the years. So this is, oh yeah, go on. Then they want to do biopsy. Absolutely. So yeah, so I didn't go into it too much, but right. So that's the summary report that came out last week really highlighted that. So I mean, in men that don't have a clinically significant or dangerous prostate cancer, they suffer still the side effects of having the biopsy and potentially receiving treatment, which, you know, things like infection. Once you have treatment for prostate cancer, there are a lot of unpleasant side effects to do with urinary incontinence, impotence, bowel side effects. Right. So there are. This is what was weighed in the risk-benefit analysis. You know, how many lives can be saved versus how many men have to suffer the side effects of potentially unnecessary treatment.
Is the PSA the driver of the cancer, or is there something else there that drives the PSA?
Yeah, that's an interesting question. So I think it's not generally thought that the PSA is the driver of the cancer. The prostate is an organ that responds to androgens. You know, it's part of the male sex hormone circuit, and it responds to androgens. And the PSA is just one of the androgen responsive or male sex hormone responsive genes. Why do cancer cells produce more PSA? I'm not completely sure. At least I'm not familiar with any research that links it directly to the cancer, only that, you know, once the cells are proliferating more actively, that they're receiving more growth signals, and then just all that machinery is ramped up, and they're producing more PSA. There's also research in, you know, one of the other maybe lesser drawbacks of the PSA test is that not all aggressive cancers produce sort of that corresponding amount of PSA that you do in some rare instances have cancers that don't produce so much PSA. But I think it's just sort of a proliferation response and not mechanistically related to the cancer. Okay. So I've always found this a fascinating chart, and I wanted to walk you through it a little bit because I think it illustrates, you know, this when we're thinking of the balance of, you know, we're thinking of the prostate cancers as a sort of a pool in the population, and we only are able to find some of them, and maybe we only want to find some of them, right? We might not want to find them all because not all men will go on to actually die of prostate cancer. There are many prostate cancers that may not even need to be found or treated, right? So this is a summary of studies that have conducted or performed autopsies on men that have died of other causes, and they've looked for prostate cancer in these men. So they never knew they had prostate cancer, they died of other reasons. And we can see quite strikingly that even in the young men, you know, the 20 to 30-year-olds, there were a small proportion that already had signs of prostate cancer in their prostates. And you can see that there's a linear increase in the prevalence of undiagnosed prostate cancer in the population with age. The other thing, which I won't talk much about today just because we only have so much time, but there's a very pronounced race disparity for prostate cancer. That in the U.S. In the U.S., that black men are almost twofold more likely to be diagnosed with the disease and more than twofold more likely to die of the disease. And so we can even see that here in the autopsy study data. So, you know, bear in mind that, you know, some of these men may have been too young to come up with symptoms of prostate cancer, but the takeaway here is that there is a lot of what we call prostate cancer present in the population, but that really not all of it needs to be treated. Some of it is very slow growing and will never affect, doesn't need to be found with the screening test. So if the purpose of screening is to diagnose the cancer earlier and so maximize the chances of successful treatment and cure, we see that on one side in prostate cancer. The introduction of the PSA screening test has shifted the age of diagnosis to about a decade earlier. So now men on average are diagnosed at about 60 years instead of 70. But we still aren't able to distinguish those prostate cancers that men die with like I showed you for the autopsy studies. We're not able to distinguish them from prostate cancers that men die from. So that's the really crux of the debate around the screening issue. Is, why expose men who will die with their disease to treatment-related side effects, if we can't distinguish these two. So this is the real exciting area in prostate cancer research, I feel, that, huge numbers of research studies to date, before, haven't considered, they're looking at risk of total disease, and that just might not be what's relevant. So this is my first take-home message, is that we need to identify the risk factors for aggressive or lethal disease, not for all prostate cancer. We're not sure about all prostate cancer. We want to know this clinically aggressive disease. All right, so the second really striking thing that I find kind of incredible, given how much research has been completed to date, is that we really don't know not a huge amount about risk factors for prostate cancer. And so the most common ones you hear about are these: older age, being of African descent, family history and genetic risk loci, so the genetic component, and then probable evidence for taller height. So, what strikes you about these risk factors? It is a bit hard to understand, and I have a slide about that later, because I think that's sort of an interesting one. But what I feel like, when we're thinking about prostate cancer prevention, we need a modifiable risk factor, right? And we can't really, maybe height is the most modifiable, but it's really not very modifiable. So, none of these risk factors can we do anything about, right? And so, I'm sorry?
Is that really true?
Is that true?
Diet and lifestyle does have an effect, and they can be.
Right,
Your
exactly.
genes are not incandescent.
Right, we could have, there's maybe ways to modify our genetic risk based on other factors. Yeah, and I'll talk. Yeah, nice. Yeah, that's a good point. I'll talk about that. But your genetic loci themselves can't be modified. I guess, okay. No, I guess you're right. They can be modified with environment. Yeah, okay. Yeah. There's actually a slightly elevated risk associated with the same genes that have been found for breast cancer, for some prostate cancers too, but nothing as striking as that for breast cancer. Maybe I should be able to, but nothing that I can name off the top of my head. Nothing that's been that really stands out. A whole lot of small effects from a number of genes is basically the answer. Now, I might have to defer that question. I don't believe so. I don't know if anyone could tell me that. Yeah. I think it's not really established, It's on the, You're right.
You must know the genes.
Yeah, but I think as I said, it's the contribution, it's contributions, small contributions from a number of genetic components, and
So they can't screen them genetically.
nothing that would be implemented as a screening test.
Okay.
Yeah, interesting idea though, yeah. Did I see someone else's?
I was just going to mention on family history. Say your family has a large breast cancer history.
Yeah.
Your potential for prostate cancer is higher also because of both sex point diseases.
Right, because there are some shared genetic factors, yeah. Could be, yeah.
My dad has a very aggressive prostate cancer, and we were just did recently, and they did a saliva-based genetic test.
Really?
I should have brought the results, they're pretty interesting.
Yeah.
A saliva-based genetic test to see if there was a family genetic
Yeah, the BRCA, yeah, the BRCA.
See if there was that. And in some respects, it's good news that there is, that he does not have that.
Yeah.
Genetic connection, which is my sister and myself and our sons.
Yeah.
But that's how I know that the doctor
But,
did
yeah.
tell us that the 23
I see.
but there are others.
Yeah, right. That might be for people who have, yeah, some indication of family history or something. Yeah. Okay. Thanks for sharing. The World Cancer Research Fund, sort of like the Preventative Services Task Force, every once in a while they go through the literature and make a summary in order to advise people about modifiable or lifestyle and diet risk factors for different cancers. And so you'll see here, I just wanted to highlight for you that they found no convincing evidence whatsoever for any modifiable risk factors for prostate cancer, although height and BMI or obesity is here with probable evidence from the literature. So I think what I'm going to tell you today is I think I know why we haven't been able to find any yet. It's because we're looking at risk factors for all prostate cancer, and we know that a lot of that prostate cancer isn't relevant. So if we are able to distinguish between types, then we have a better chance of success. So I wanted to show you some of the reasons, some of my reasoning. We need modifiable risk factors for prostate cancer. All right, so I think maybe we're all sort of on board with that there must be risk factors for prostate cancer that we just don't know about yet. But I thought this global variation in prostate cancer incidence gives you an idea that there must be some modifiable risk factors, right? Otherwise, why would we have such pronounced global variation around the world? Of course, you could argue that it's just because of screening. We know that screening, dramatically increases the numbers of prostate cancer cases diagnosed. But this global variation in incidence, so here the darker colors represent the countries with higher numbers of cases diagnosed. Even before the mid-90s, when PSA screening was introduced, we still saw this variation, and we see it for other cancers too. That Asian countries tend to have lower risk, and then these more westernized countries have higher risk. We also see evidence that there must be diet and lifestyle factors for prostate cancer from migration studies. So we know that within a generation, say when Asian men move to the US, they acquire the prostate cancer risk of their US counterparts. And so it's not all genetics. There must be some dietary factors also, as well as the interaction between the two. Yeah. I'm sorry? A conspiracy theory, yeah.
The prevalence of the pharmaceutical industry seems to be greatest in North America. Is that Brazil?
Yeah, I think so.
In Europe? I would think that the pharmaceutical industry would get a lot out of aggressive screening.
Yeah.
The more cases that are diagnosed, the more infusion stuff they're going to sell, the more surgical supplies they're going to sell, the more prostate medications they're going to sell. So how do you factor into big pharma?
Do you know, I've never thought about that conspiracy theory. I mean, prostate cancer later in its clinical progression does rely heavily on expensive new drugs that are sort of coming on the market every few months, that generally only, patients are only on them for short periods of time and then they're on to the next and the next, and yeah, there must be a lot of money in it. Do you have a response?
No, I'm just curious, in line with that thinking, is there any correlation? We take a lot of drugs in this country.
Yeah.
The average American, people in their 70s on 10, 12 different medications.
Yeah.
Whereas in parts of Africa,
I know, but they're not. Yeah.
I mean,
Yeah.
could there be a correlation there? Not with that maybe, but also just particular drugs.
Yeah.
Antibiotics. I mean, the average opinions, it's almost zero.
Yeah, yeah.
Could there be
Yeah,
have you
true.
studied that?
I don't know if a lot of, so there's more and more research, and I feel like some of the NRI research is in this area, looking at, not antibiotics per se, but say the presence of a healthy gut microbiome, and those kinds of exposures in relation to cancer and other diseases. And so I feel like it's a bit disappointing just to say that, there hasn't been, we're very early on in research in those kinds of areas.
I'm surprised.
About what?
That so little research has been done yet.
I think it's striking that there are no risk factors identified for prostate cancer. I guess research efforts maybe have focused more on the treatment and, drug development.
They're looking at Alzheimer's, they're doing a lot of research on different antihistamines and other benzoids that have an effect on Alzheimer's. So I'm just curious why they don't look at
For
the
prostate.
accumulation of all the different drugs.
So there is research on drugs, but generally what I've seen, I suppose, there's a few things because obesity and diabetes has been a proposed risk factor for prostate cancer, and so then there's been a lot of research studying metformin and anti-diabetic drugs, but more with the idea that they might counteract some of the risk associated with having diabetes. That they might reduce the risk of prostate cancer in obese men. Yeah.
You said that people from other countries that are low risk that come to the U.S. get high risk. So could a test be done? Here they come, take the test with particular enzymes or whatever, and then after they've been here, what's changed?
Yeah, interesting. The diet, yeah. Well, I thought there were a few, in the autopsy graph I showed you. Maybe it's too far to go back. I mean, you do see it here. Although, actually, in saying that, these aren't U.S. Asian population. Yeah, it'd be interesting. The trouble with any molecular understanding tumor factors in prostate cancer is that it's not very pleasant to undergo a biopsy to give tissue for research, and it's kind of like, I suppose it's a bit like other cancers in that regard. But I know it seems tiring. All right. So that's one of the limitations in the area of research I'm in. I'm interested in looking at biological changes in the tissue, and then of course you're limited to the tissue that you can get. Yeah.
Has anyone ever noticed a correlation with higher levels of meat consumption?
I have a slide on that. Maybe I should keep going. So these were the two things I wanted to talk to you about, and I'll get to some of the more examples of the research, which I think will be good. So the two reasons that I think we haven't been able to identify a lot of risk factors yet is because we know that prostate cancer is heterogeneous. I mean, it's not helpful to lump it all together. We have to distinguish between the more aggressive forms and the indolent forms. And then second, and this is why I've been interested in spending 6 months at the NRI, is that we do see variation between individuals in response to diet, as you pointed out. So yeah, I'm sorry now you have to listen. I don't have a research slide yet, but I think it's the next one. But I wanted to give two ways of distinguishing the different types of prostate cancer. The first is the historical, traditional way, using the pathologist. And this is a diagram of how the pathologist distinguishes between different types of prostate cancer from a biopsy. So this is a piece of biopsy tissue, and someone's made a cartoon of sort of the morphology or what the tissue looks like, what the pathologist sees down the microscope. And so this roughly corresponds, I got some pictures of actual tissue because I thought that was more interesting. So the Gleason pattern 3, for some reason in prostate cancer, the pathologists don't even bother grading 1 and 2 anymore. And I think this has happened over decades of clinical practice. So Gleason 3 is the lowest grade you see. And you can see it says many abnormal cells here, but you can see they're still arranged kind of neatly in ducts, whereas if you see the higher grades, grade 4 is one step up. They're a little bit more disordered. And then grade 5, even more disordered. You can't even see the duct formation anymore. So this is, generally speaking, how prostate cancer has been classified traditionally. So you get 2 scores when you have a pathologist review the tumor tissue, and you add the scores. So 3 plus 3 is the lowest, that's a 6, and this is pretty good prognosis prostate cancer, the kind of prostate cancer that you might get put on active surveillance for, not even be treated for. So this is how the pathologist can tease apart that, prostate cancer that men die with versus prostate cancer that men are more likely to die from, which is the more aggressive tumors. And so this is one way of distinguishing.
So if you have like a 3, they're not even going to treat you? Or are they going to wait
Recently,
and test you again? And if it's
they wait and test you again.
really
It's now known that it's just very slow growing, and knowing, the balance of the potential side effects of treatment. The patient would have an opportunity to weigh in, but now it's called active surveillance is being much more widely taken up, and that involves PSA testing and rebiopsying at regular intervals without treatment. Yeah.
Wouldn't enter into the calculations of the physician as to the age of the patient that has the Gleason score of 6.
Yeah.
If you're 70, 72, and you have a Gleason score of 6,
Yeah.
no big deal.
Yeah.
If you're 40 or 39 or 38, and you have a Gleason score of 6, there's a problem. So I think you can't just walk saying that Gleason 6 is
Not a problem.
issue.
Yeah.
If you've got a Gleason 6 at 30 or 40,
Yeah.
you've got longer life expectancy, much longer time for that Gleason score to change to 5.
Yeah.
Usually more
So
aggressive.
yeah, so I take what you're saying, but I also, there are many that would counteract that by saying that we don't know if Gleason pattern 3 becomes Gleason pattern 5. Like from those autopsy studies and from other research, often Gleason pattern 3. Maybe I should add the caveat that, how would a Gleason pattern 3 even be diagnosed in a 30-year-old? It would be extremely rare because they're not undergoing screening, and it wouldn't come to clinical attention otherwise. So it's maybe more of a theoretical question. But I agree with your point in general that, a cancer in an 80-year-old is different from a cancer in a 60-year-old, say. And I think, prostate cancer is increasingly managed by multidisciplinary teams, and, I guess it's weighing the risks and benefits of treatment, along with information that the physician would have on, anticipated life expectancy, other comorbid conditions, kind of the whole picture. But increasingly, this type of prostate cancer is no longer, not so commonly being actively treated anymore. So if that's the case, then what we as researchers want to do is identify risk factors for these cancers, the more aggressive ones of diagnosis. And I just wanted to illustrate, this is from a recent review by a group that I work with, and it's just listing some of the risk factors that have been studied in relation to prostate cancer, and I'll give you a little bit more detail in the coming slides. But here I just wanted to highlight that this review, actually this is where I got the table showing the established risk factors for prostate cancer, which were the age, the African descent, genetics, and they saw no associations with any of these more modifiable factors and total risk of prostate cancer, right? So this is my point, that when we classify prostate cancer, like the pathologists now do, separating it into the prostate cancer that can be left to be go under surveillance versus the prostate cancer that really needs to be treated because we think it's aggressive or lethal. Then we start to see different patterns of risk factor associations for prostate cancer. So for the first time, I think studies in the last 10 or 20 years have been starting to do this classification more routinely, and so we have accumulating evidence now for risk factors for aggressive prostate cancer. And so now we know that obesity is not associated with all prostate cancers, but it is associated with increased risk of being diagnosed with a more aggressive form of the disease. And similarly for some of these other risk factors. Physical activity, not associated overall, but seems to be associated with reduced risk of this more lethal disease. Statin use is one of the drugs that I've been studying in collaboration with this group as well, actually, and we see that it's really has a role and is associated with prevention of lethal disease. And then we also see these patterns for smoking, and then I'll mention, or maybe I don't mention coffee, and I'll mention tomato intake. An example of statin use. They're cholesterol-lowering drugs. Yeah, yeah. I think I heard. Was everyone saying names of statins? You have to have what you said? Yeah, you'd have to. Yeah. Yeah, you would. Yeah, yeah. But they're very prevalent. So maybe, yeah, maybe a third of the U.S. population, something huge like that. It's really a lot of people.
Is it because it's neutral, or is it actually reducing?
It's reducing the risk. So for statin use, a number of large studies now have shown that statin users have a lower risk of being diagnosed with more aggressive or lethal prostate cancer than non-users.
Coffee, tomato-wise, do they know what's in there, what the ingredients are?
In the coffee and the tomatoes. Yeah, I think there's research going into coffee now, and I don't think I have any slides on it. There are a variety of bioactive compounds in coffee, the names of which I aren't on my fingertips, but yeah, I believe it's seen for it's not the caffeine, it's other bioactive components. And then the tomato, it's thought to be an antioxidant molecule called lycopene present in the tomatoes that prevents DNA damage. And I have a couple slides on tomato. If I get there, maybe So that's the pathologist's way of classifying prostate cancer, and that's brought us some progress in the research, right? So the other way of classifying prostate cancer, and I mentioned I have a lab background, and I'm interested in understanding the molecules and the biology of the tumor and the tissue itself. And so this is a little summary that I won't go through in detail, but I just wanted to give you an idea of, it's sort of laid out like a pie chart, and it just shows you the molecular or biological subtypes of the disease that have been identified. And so rather than just looking, or I shouldn't say just, rather than examining the morphology or what the disease appears like under the microscope, this is the result of, advances in biotechnology and molecular tests that, crunch up the tissue and examine different genes and pathways and molecules expressed by the tumor itself. And so I'm going to mention two common tumor markers or biological pathways in prostate cancer. One is this ERG protein, and then one is the P10 protein. So what are they? Well, both are genes that we find in the prostate as well as other organs in the body. Here's a little picture of DNA. So ERG is just one of these genes. And prostate cancer is sort of interesting in that, uniquely from many other cancer types, it actually has a gene fusion of this ERG gene with another gene that can drive tumor growth. And so this is sort of a trick that the prostate tumor uses to advance its own growth. And actually we see that this gene fusion is present in about half of all prostate cancers. So this is a really common mechanism that tumors use to grow, to kind of overcome the normal checks and balances that prevent tumors from proliferating. And so TMPRSS2, the name of this gene, is triggered in response to androgens, and the prostate has a lot of androgens around, and so this is driven by androgens or by hormones. And then this is an oncogene, which just means when it's expressed in high quantities, it can drive tumor growth. And so the fusion of these two genes together allows this oncogene or cancer-causing gene to be expressed at high levels in response to hormone signaling, which occurs in the prostate. So sort of a trick used by the tumor cells to proliferate. But maybe also, if you remember that this is a hormone-driven gene fusion, maybe makes the prostate more susceptible to hormonal risk factors.
Do you think that has any variance if the patient is given hormone therapy as part of the treatment plan?
Yeah, interesting. I'm not in the looking at prostate cancer risk research. I guess I haven't encountered a lot of those studies, so initially when this protein was discovered, there was a lot of enthusiasm for it because we thought that it might help us resolve some of the biological challenges and improve our understanding of prostate cancer. But early on, it was found that it doesn't actually predict your prognosis or response to treatment. So men with and without this gene fusion actually sort of do equally well or badly. It can't distinguish. And so I think it doesn't predict like who responds better to androgen deprivation therapy or anything. It's been a little bit disappointing in that regard. But the research into prostate cancer risk factors, I feel like has gotten the most out of this discovery because it's allowed us to separate different risk factors for these two different forms of the disease. But regarding an effect on prognosis or response to treatment, it hasn't really produced anything. Actually, the more prognostic gene is P10, so this is the other molecular marker that I'm going to talk about or mention briefly. And so this is a tumor suppressor gene. And so if it's expressed, it reduces the tumor growth. So it's sort of the opposite of this oncogene. And these are little scissors, if you can see. So often in prostate tumors, the tumor just loses this gene completely. So it can promote its. It's no longer checking its tumor growth. It just loses it, so that it doesn't have those breaks on. And actually, this is a very prognostic gene in prostate cancer. That if men who've lost this gene have poorer outcomes. And it's found generally in the more aggressive prostate cancers, but in a relatively sizable proportion of prostate cancer cases too. So research into risk factors according to these different types of prostate cancer has just begun in, say, the last 5 years or so. So we're starting to learn a bit more from this molecular work. And I thought, I wasn't sure how many of you look at graphs every day, so I thought I'd just give like a brief 30-second overview of the types of data I'm going to show you. I hope I'm not going too slowly. But this is a graph, and it shows you on the x-axis, the horizontal axis, so this is the relative risk of prostate cancer. I'm going to show you here. And so anything that appears to the left of the line is associated with a lower risk of being diagnosed with prostate cancer. So for example, I'm going to show you something that looks like this. So this is the estimate of the effect, and this is our confidence in how accurate it is. And so you can see this is about a 40% lower risk of prostate cancer. That's the type of thing you're going to be looking for, right? Anything on the right of the line then is a higher risk of prostate cancer. And so there's an example of one over there. If they cross the line, then they're not statistically significant, or it's sort of equivalent to no effect at all. All right, so I thought I'd just share some of the research that this more molecular understanding of prostate cancer has led us in the last few years. And you can see that these are all new papers, so this is really the research that's going on at the moment. And so I mentioned at the beginning of the talk that taller height was associated with prostate cancer, which is always kind of a confusing one to people, But here we can see that it's actually a pretty borderline association, right? So remember, I told you that if it crosses that center line, it's not really significantly associated with prostate cancer risk. But it is to the right, right? So it's each 5-inch increase in height is associated with a 10% elevated risk of being diagnosed with prostate cancer. And so that's what the literature came from that first table. But there's some uncertainty in that estimate, right? If we classify prostate cancer according to one of those molecular markers that I showed you, this more potentially hormone-responsive ERG gene fusion, we see a stronger effect for the association between height and prostate cancer. So slightly further to the right, at about a 20% increased risk of prostate cancer for every 5 inches in height. But we see nothing going on at all for prostate cancers that don't have this fusion protein. And so there hasn't been a lot of research done, but we hypothesize that it could be that taller men are exposed to higher levels of growth hormones, particularly during puberty, and that this exposure to higher growth hormone levels could particularly increase risk for this hormone-driven prostate cancer. Yeah.
I hear commercials on the radio and on TV for, products for men like androgel,
Yeah.
That's for testosterone.
Yeah. So, but there are a lot of products for. Again, I'm not really familiar with them, but there's been some research looking at their association with prostate cancer. Actually, interesting. We think of the prostate as a hormone responsive organ, and prostate cancer is a hormone-dependent disease, at least in its earlier phases. But there hasn't actually been a lot of convincing research on levels of testosterone and risk of prostate cancer. So I guess there could be multiple reasons, but circulating levels of sex hormones. I guess they vary throughout life, and they're tough to measure, and maybe there's a lot of error in capturing that, but there interestingly hasn't been much evidence linking higher levels of sex hormones with prostate cancer risk. Again, most studies have looked at all prostate cancer. Yeah. Oh, right. Like, what's a safe height? Yeah, I'd have to. From where? I know, yeah. Per 5 inches. Let me see now. I think to answer that, I'd have to go back and look at. So a lot of these studies that I'm going to show you for the molecular subtypes of prostate cancer were completed in the health professionals follow-up study, because they're one of the few studies actually that are really large and that have invested a lot in these biological assays to measure these things. And so they were a cohort that started in the 80s. They recruited 50,000 men, and they've been following them and bothering them with questionnaires every 2 years for the last 30 years. And so quite a few of them have developed prostate cancer now, and it's providing a lot of our data on understanding risk factors at this point. So I can only assume they're about our height, but whatever average height is, I'd have to look back to remind myself. Thanks, Felicia.
American man's about 5'9".
Is that right? Yeah. Okay. Yeah. Yeah.
When we refer to the growth hormones, would that include human growth hormone, HGH? Because some people are making efforts to increase their HGH. Would that be a bad path to be on?
You mean for sports or something? Or why?
Through lifestyle and diet, some people try to increase their levels of HGH.
It's so some of the research that I feel like is interesting in this area is some studies have now shown that it's really that growth spurt in adolescence that is sort of the window where these hormones might be relevant. In adulthood, I guess more research could be done, but I think a few of the studies I've read have really focused in on childhood and adolescent height. When the prostate, which is an interesting window of time, in the teenage years, the prostate is developing and could potentially be more susceptible to different exposures. Of course, it's a tough window in time to study because you either need to be questioning teenagers, which I believe is difficult, and then waiting until they develop prostate cancer, or asking men in their 50s and 60s to remember things about their lifestyle in their teens. And of course, it's tough to know growth hormone levels during that time period, but that's part of the thinking, is that when the prostate is developing, that exposure to higher levels of growth hormones could potentially have a small effect. So I wanted to show you also for obesity and prostate cancer. So there's been actually quite a number. I feel like obesity has been a really hot topic in cancer for quite a number of years. And I mentioned that it was associated with an increased risk of being diagnosed with a more aggressive form of prostate cancer, as the pathologist would classify it. But now we're also seeing that it's more strongly associated with this potentially more hormonal-driven prostate cancer also. So per 5-unit increase in BMI, and again, I haven't given you the reference category here, but for every increase in BMI over sort of the average, this is the same study, we saw, this group saw about a twofold increased risk of being diagnosed with this particular form of prostate cancer, the ERG-positive prostate cancer. So again, we can't determine mechanism from these large human studies, but that potentially we know that obesity is associated with altered levels of sex hormones, and potentially also that chronic inflammation, blood inflammation, circulating inflammation could play a role. It's been a hypothesized mechanism linking obesity and cancer as well. I said I'd share something about lycopene. So this research from this cohort has also been produced for the association between lycopene or tomato sauce and prostate cancer. And so they studied various sources of lycopene, but actually found the strongest association for tomato sauce. So I'm showing that here. And so they examined, here's some more definite numbers actually. These were estimates for the risk of prostate cancer in men who ate at least 1 cup a week of tomato sauce versus those who ate less than half a cup a month. So, I guess, in sauces and soups, pizza, those kinds of things. And we saw that the men that had higher tomato sauce intake, this group found that they had roughly a 50% reduced increase of being diagnosed with this type of prostate cancer. We know that lycopene has antioxidant properties. So this is what they proposed, is that in order for this gene fusion to be formed, if you remember, this is the result of the fusion of two different genes together, there has to be some DNA damage. And so oxidation provides this DNA damage, and so it could stand to reason that an antioxidant would help to prevent the DNA damage that may be required to produce that gene fusion. Oh, and finally, the study that I'm working on with them now is looking at statins and prostate cancer. So we're looking at the risk of prostate cancer in current statin users versus past or never statin users in this cohort. And we don't see any effect of statin use on prostate cancer risk for all prostate cancers. And we didn't actually see anything with the ERG fusion protein either. But we saw that statin use was associated with quite a substantial, like 50% lower risk of being diagnosed with a P10 null prostate cancer, a prostate cancer that tumor suppressor P10 gene has been just dropped. And I mentioned in passing that these are actually the cancers that tend to be associated with worse outcomes. They're more aggressive. And so this may provide at least some insight into the quite substantial body of evidence now that suggests that statin use is associated with less risk of dying from prostate cancer. We know very little about what the statins are actually doing, but we think it could be the reduction of blood cholesterol. We've also been looking into, I mentioned inflammation earlier, that statins, that we and others have shown that they have anti-inflammatory effects on the prostate itself also. All right, so here's a little summary diagram. So here I'm showing you the prostate, and here's the prostate cancer, this little yellow star. And so if we don't know much about it, we are unsure of the progress from the normal prostate to the prostate cancer, right? We don't know much about the risk factors. But understanding a little bit about the biology of the disease, so identifying this fusion gene that could drive this tumor, enables us to then hypothesize that, well, obesity and taller height through their effects on hormones might drive particularly this type of prostate cancer, whereas, say, lycopene intake, because it prevents this DNA damage required for the gene fusion, might be associated with less of this gene fusion positive prostate cancer. And so the take-home message here is that understanding more about the tumor biology could uncover some prostate cancer risk factors and finally get us to a point where we can start to understand things, risk factors, modifiable risk factors that could be causes for prostate cancer. All right. I wanted to take a little sidebar here because I also think this graph or chart is really striking. This is a summary of the number of people who have been diagnosed and are currently living with cancer in the US. It's produced by the American Cancer Society on a regular basis. And so here we see sort of close to today, 2016, and then they've projected the numbers a decade into the future. And so you'll notice that prostate cancer, it's usually close to the top of the list, but here it's top of the list. So today, about 3.5 million men living with prostate cancer in the US, projected to increase to about 4.5 million in the next decade. And so I feel like I was really struck by this because, maybe we not only need to identify risk factors for being newly diagnosed with the disease, but, how can we best provide diet and lifestyle recommendations to people who've already been diagnosed with prostate cancer. And so I think there's a huge amount of research that needs to be done in this area also. All right, so I've talked to you a little bit about prostate cancer heterogeneity, and then I wanted to end by sharing a little bit of research on the precision nutrition angle, the variation between individuals in response to diet with respect to prostate cancer risk. And so I'll start. I got inspiration from Martin Kohlmeier when I arrived at NRI, who showed me this study, and actually I haven't been able to find any that were published since, so I've included it here, but it's looking at intake of lycopene, which is the tomato sauce data that I showed you a few slides ago, lycopene intake, and genotype. So this gene is involved in DNA damage repair. And so I mentioned before that lycopene is this antioxidant that may have a role in preventing DNA damage. And so the genotype that you have with relation to this DNA damage repair gene appears to modify the association with lycopene intake. And so lycopene intake is only protective for prostate cancer risk in men that have this particular DNA damage, so that maybe they have insufficient DNA damage repair. And that's really where we see the positive effect of increasing lycopene intake. So an illustration of how knowing something about genetic information could maybe let you know that you could be modifying your diet somewhat. I promised a slide on meat. Maybe it wasn't necessarily charred, but this one is on charred meat. And here we have the study. Actually, they use sort of a complex method to estimate meat carcinogen levels. So I hope no one will ask me about that. I didn't check what that was, but they looked at meat carcinogen levels in the diet, and then looked at modification by this carcinogen metabolism gene. And so it's thought that they haven't completely worked out the mechanism, but it's thought that this genotype has higher levels of this gene, and so more meat carcinogens are processed, and so there's higher levels of carcinogens in the prostate. And so we see that it's really only among individuals with this genotype that have an excess risk of prostate cancer when they're eating a lot of a high amount of charred meat.
So that was well done. And we,
Yeah, I mean, it's really the there are some There are molecules produced by this method of cooking, the high temperature, and that have been identified, the polycyclic amines. There's well characterized molecules that arise from these cooking methods that explain this association. I think there have been evidence for this. Now, in saying that, this study I don't believe examined smoked foods, but I have seen that for other studies that there are some of the same compounds present in smoked foods. I mean, all of these things, I feel like you read the press releases of these papers and generally are counselled to consume things in moderation. But it's interesting that maybe particularly certain individuals should be avoiding these types of meats more than others. And then finally, I wanted to share another. I mentioned that there haven't been a lot of dietary risk factors for prostate cancer, but calcium is one of the ones that has been studied a little bit, dairy intake or calcium. And so generally, studies have found it to be a risk factor associated with increased risk of prostate cancer, high calcium intake. And here we see that this polymorphism in the vitamin D receptor, which modifies how much calcium you can absorb from your diet. So if you're,
The plant-based calcium sources have the same potential.
Well,
because of the
hang on.
hormones in the dairy.
Right.
And the plant-based,
Right.
I'm surprised that.
So actually, this source list is kind of independent of this study. I'll mention. This study looked at dairy calcium intake, whereas here I'm just listing.
Kale's a superfood.
Yeah, I know. Yeah, I know. Yeah, poor kale. No, I know. Yeah. So here we see, that among the individuals that have lower calcium absorption, that this if they have also low intake, that this is associated with lower risk. It's sort of the flip side of the other, since lower calcium is hypothesized to be more protective for prostate cancer risk. Of course, these things all have to be balanced in the context of nutrient requirements for other things in addition to prostate cancer. So the final take-home message then from that is that understanding those genetic differences between individuals could identify people who would benefit from certain dietary changes to modify their risk of prostate or of aggressive prostate cancer. All right. There's been some interesting research on vitamin D. Let me see. What do I have to say about that? There's been some evidence showing, maybe not so much in prostate cancer, in a number of cancers, showing a role for vitamin D. Certainly, yeah. I mean, I'm not completely up to date on the literature. Some interesting studies have actually, because I feel like, I haven't mentioned today, but one of the big clinical relevant questions in prostate cancer is to identify causes of race disparities, and I think a lot of them are access to care and treatment related, but there has been some research looking at vitamin D. The latitude that you live at, the color of your skin, how your vitamin D those proxies for vitamin D levels. And so there's been a little bit of research in relation to prostate cancer, but nothing, I guess, overwhelmingly convincing. But yeah, it's an interesting area. So I guess, yeah, I should have brought a watch, but I'm going to summarize here. Yeah? Okay. Great. So I mentioned that our unmet need was modifiable risk factors for prostate cancer. And the reason that this has been challenging in the past is that we have a disease with really complex tumor biology that we're just starting to learn about, as well as inter-individual genetic differences which complicate our understanding of how individuals respond to diet. And so that makes the whole area for research quite complex. So I believe the solution is a little bit of what I've shown you, to incorporate some molecular and genetic data into our studies of diet and prostate cancer. And we're more and more able to do that. And I think it's an exciting time to be in the research field, because it's only in the last 5 or 10 years that we're starting to see more of those studies and have a better understanding of what are relevant markers to examine. So I feel like the whole field is now open for this new stage. And then I think our payoff will be an important one, that we'll be able to more precisely intervene to prevent prostate cancer. And of course, I'm interested in prostate cancer prevention in the first instance, but also thinking about how we can adapt recommendations to help men already diagnosed with prostate cancer too. And with that, these are all the people that I'm lucky enough to work with. So I'm very grateful to them, and also to you for your interesting questions throughout the presentation and your attention this long time. Thank you very much.